So when we do the respiratory system, we divide it into two parts, an upper respiratory tract and a lower respiratory tract. And you may have heard, when you have a cold or a bit of a cough and the doctor tells you you have an upper respiratory infection, right? So what exactly are they talking about? So the upper respiratory tract starts with the nasal cavities, the pharynx, which you did when we were doing the lymphatic system, and it goes to the larynx, which is also called the voice box, though I don't want you all to be calling it the voice box, okay? The lower respiratory tract is from the trachea down to the bronchi and finally to the lungs. So that's one anatomical division. Functionally, we divide it based on whether the portion just conducts air or whether the portion is involved in gas exchange. So just going back here, from trachea I went to bronchi and then I went straight to the lungs. Actually these bronchi, you remember when we did the cardiovascular system, we did arteries and then they got smaller and smaller and we call them arterioles, right? So same way, bronchi, we have many generations of bronchi. So you will be taking a look at that. When bronchi become really small, they are known as bronchioles. And bronchioles do not have cartilage in them. And in fact, in your notes, you will find a histological portion. There's histology on the various parts. I will not be doing the histology in class. I want you to read that on your own. But you'll see that bronchioles are much smaller when the diameter becomes 1 millimeter and they lack cartilage. So, and then bronchioles finally lead into the alveoli of lungs, okay? So they are also part of the lower respiratory tract. And so now when we come back to function, the part which just conducts air is known as the conducting zone. And so that is from the nasal cavity all the way down to the bronchioles. So up here, it's just air being conducted all the way down, or when you breathe out, air goes out through this part. And then we have a respiratory zone, which is where gas exchange takes place. So here, it is just air conduction. So that's why you call it the conducting zone. And respiratory zone is where gas exchange takes place. And this is from a particular type of bronchiole which is known as the respiratory bronchiole. So you can see the word respiratory is a prefix here. From the respiratory bronchiole, it goes on till the alveoli. So you might have the question, you have a bronchiole here and you have a bronchiole here. What's the difference between the two, right? This bronchiole is from a bronchus which has cartilage around it. Let's say it becomes 1 millimeter and loses cartilage, we call it a bronchiole. But it's still a straight tube like this. This, when it gets even smaller and smaller and smaller, it finally leads to a respiratory bronchiole which actually has alveoli budding out from its walls like this. So you can see a respiratory bronchiole is a tube which is interrupted by alveoli between them, okay? So here, this would be a regular bronchiole. And this part here is a respiratory bronchiole where you have alveoli budding out from the wall. Then I also want you to pay attention up here to this part. We did the cardiovascular system and we talked of how from the right ventricle through the pulmonary trunk into the pulmonary arteries, blood went to the lungs. And they formed pulmonary capillaries, and then we said pulmonary veins came out from the lungs and came into the left atrium. So let's kind of tie the cardiovascular and the respiratory system together. So here we have a bronchiole, a regular bronchiole, and if it's the last part of the bronchiole, we call it a terminal bronchiole. And following this is the pulmonary, a branch of the pulmonary artery and the pulmonary vein. And notice how you have these capillaries which are present here. See this capillary plexus? And this capillary plexus is actually surrounding, it's lying on the outside of the walls of the alveoli. Here in the lungs, here are the walls of the alveoli. And in between one alveolus and the other alveolus is a septum which is present, which is called the interalveolar septum. So the alveoli are like bunches of grapes like this. Okay, so this is the wall between the two alveoli, so that's why it's called interalveolar septum. And these capillaries are lying in the interalveolar septum. So if I show you the capillary plexus, they actually lie here like this, so that carbon dioxide, which is being carried by pulmonary arteries, will get into the alveoli. You take in oxygen, oxygen from the alveoli will get into the capillary, and these capillaries will form pulmonary veins. So can you see how gas exchange can occur there? Okay, so that's how the cardiovascular and the respiratory systems are connected. So notice up here, so this artery, this capillary plexus, you notice it has a blue part to it and a red part to it. The blue is the deoxygenated, the red is the oxygenated. So carbon dioxide from the deoxygenated part gets into the alveolus, and oxygen from the alveolus gets into this red portion, comes into the veins, and that's how it's brought back into the left atrium. Okay? So some important facts to remember, that when you are born, it isn't as if your lungs are completely developed. After birth, till about the 8th year, the respiratory bronchioles begin to increase in number, and about alveoli also increase in number. So that's why 95% of your alveoli actually develop after birth. And if you remember again from ANP1, when we did squamous epithelium, remember we said one of the areas where squamous epithelium was found in was the air sacs or the alveoli of the lungs. Okay, in the alveoli of the lungs, so if I take one alveolus like this, in this alveolus of the lung, there are two types of cells which are present. The flat squamous cells are known as type 1 cells. And then in between you have a few cuboidal cells present. Those are known as type 2 cells. And these type 2 cells are important because they produce a secretion which is known as surfactant. Surfactant production starts at about 20 weeks when the child is inside the uterus. So 20 weeks of what is called intrauterine life. Around 20 weeks, and then it continues to, as the baby is growing, it continues more and more of surfactant production goes on. So your question should be like, what is the purpose of surfactant? Whenever you have water molecules tend to adhere to one another. Okay, so if you take two glass slides and you put a little water between them, you can kind of roll the slides between the two, but it's very difficult to get them apart, right? Water molecules tend to kind of stick to one another. Now remember, from the respiratory tract, so here you have the trachea and the bronchi and so on, and this trachea goes up here into the nasal cavity, right? So your epithelium has goblet cells which produce mucus. All of that mucus will travel all the way down till it will come to the alveoli. So up here in the alveoli, you have little few water molecules which is part of that mucus. So what is it going to do? It's going to make the alveolar walls come close to each other or stick together. If alveolar walls stuck together, what would happen? The alveolus would collapse. You need something, and this water molecule, the tendency of water molecules to stick together is known as surface tension. You need something to decrease the surface tension so that the alveoli can be inflated and so that air can go in. That is what surfactant does. It decreases the surface tension and allows the alveoli to be inflated so that air can be got in. Okay? But remember, surfactant production starts at 20 weeks, and actually by about 28 weeks it's a bit adequate, and then it goes on more. So you may have noticed that premature babies, normal term fetus is about 40 weeks. Anytime if the baby is born between 36 weeks to 40 weeks, it's good. But if a child is born before 36 weeks of pregnancy have been completed, we call such children preterm babies. That means they are not producing enough surfactant, and the more preterm it is, the worse it is for the child. So when they don't produce enough surfactant, what happens? The alveoli tend to stick to one another. If they stick to one another, they would be collapsed. So if you look up here, this is a case where the surfactant has not been produced. Notice how the alveolar walls have collapsed. This is a case where the surfactant production is adequate. See how well inflated the alveoli are. So if your alveoli are not inflated and they are stuck together, what is the first thing you think the child is going to suffer from? Not able to get enough air, which means they'll have respiratory distress. So when not enough surfactant is produced, you get a condition which is known as infant respiratory distress syndrome. So do you understand why this would happen? Okay, that's why they are kept in incubators. One, they are small, and second, so many other systems are not developed properly. Then the pediatricians will actually spray surfactant, synthetic surfactant through their nose so that it can go in and help the alveoli inflate. They also give them corticosteroids because steroids help these type 2 cells produce. They help them produce the surfactant.
Kind of the hallmark, I guess, of premature babies. They always say, how are the lungs developed or not? Is this what they're
This is exactly this, because the child has to be able to breathe on its own. If the alveoli are not inflating, it's not going to be able to do that, okay? So let's, based on whatever information I gave you so far, suppose let's say a 3-year-old child keeps having, children go into the daycare, they often have respiratory infections, and this child has had several since his first birthday. Do you think this will affect his respiratory function in the future? Yes, it will, because remember, alveoli develop till about 8 years. So the younger the child and the more the infections obviously are going to be hitting at something which is developing. So the child then, his or her respiratory function is affected. Now, here's another one. So if someone has a lack of surfactant, and please do make sure, some questions I've repeated here, but many questions are asked within your notes. So please make sure, there are little quiz questions within your notes. So please, when you're looking at your notes, make sure you kind of go through those quiz questions. So what do you think lack of surfactant will result in? Gas exchange problems, or conduction of air, or production of pleural fluid? And I haven't discussed pleural fluid. But you might know something. Okay, very good. Well, half the class got it right. Yes, because remember, where does surfactant act to inflate the alveoli? What happens at the alveoli? Gas exchange, right? So that's what is going to be affected. It will not affect conduction of air, because remember, conduction of air is going from the nose all the way down. It'll pass through the nose properly, it'll pass through the trachea, it'll pass through the bronchioles. Surfactant is not acting there. So all that passage is clear. So that will not be affected, but it'll affect gas exchange because the alveoli will not be inflated. Here's now we come to the various parts, nasal cavities. So the external nose is part bony and part cartilaginous. This cartilaginous part is all hyaline cartilage. And you have two kind of openings. Each one is known as the nasal cavity. And when you look at the nasal cavity, and I want to go back here, this part here inside would be the lateral wall of one nasal cavity. There's a septum in the middle, so that would be the medial wall. So you can see the septum belongs to both nasal cavities. So this side here is the lateral nasal cavity. So here is a picture where the septum has been removed. So the septum would really be lying on top like this, okay? The septum has been removed, so now we are looking at the lateral part of the nasal cavity. When you peep into your nose, and I know all of you have done it at some point or the other in the mirror, all you're really being able to see is this portion of your lateral nasal wall. But if you were to actually look deep inside your nasal cavity on the lateral part of your nasal wall, you will actually see 3 shelves made of bone, and these are covered by the mucous membrane, which is the pseudostratified ciliated epithelium with goblet cells, which is part of the nasal epithelium. These 3 bones or plates of bones which are present are known as conchae, concha is singular, or turbinates. And in between these turbinates are spaces. Because there are 3 of these, we call them superior, middle, and inferior concha. And there's a sort of a space that you can see below each of the turbinates. So the space below the concha has got the name, the corresponding prefix, and the space is known as the meatus. So here, for example, would be below the superior concha would be superior meatus. Below the middle concha would be middle meatus. Below the inferior concha is inferior meatus. Okay? Together, meatuses are called meati. That is the plural. The function of these turbinates is that they are like little shells which will, as air passes through here, instead of air just going through like that and coming into the nasopharynx and going down, what it does is these conchae kind of block the air, and they set up little turbulent eddy currents up here. So it makes the air stay longer up in the nasal cavity, and this helps to humidify the air because all of this has the pseudostratified ciliated epithelium with goblet cells. So the mucus will help to humidify the air. It helps to make the air come to your body temperature, again because of blood vessels present there. The cilia over there will remove any particulate matter so that it doesn't go in. So that's the function of these turbinates. Into these meati, yes?
The little hairs that are in the nose,
Those are here.
Yeah.
Doesn't
that help to...
Yes, those little hairs also help to take out really major particles. The cilia would be for very, very minute particulate matter. It does it twice. You want to make sure it does it as many times as possible, because even the mucus from the goblet cells will trap the particulate matter, and then you kind of blow it out if it irritates your nose, or it'll just go back and you swallow that. Okay, so as many times as you can block particulate matter from going, it works.
I've got one of my weird questions. So if you trim your nose hairs really, really short, is that going to make you more likely to have...
No. Yeah, the nose, if you trim your nose hair, and you're not really going to affect your thing so much, the nose hair basically is for really large particulate matter. You're on a windy day if you're going out, and you get dust really big, which you can actually see. That's what it's taking out. No, that's not really going to affect you too much. So in the meati, surrounding your nasal cavity are sinuses. I mean, you've all suffered probably from a sinus infection at some time or the other. These sinuses surround your nasal cavity, and ANP1, you saw that in the bones you had these sinuses, and the 4 bones that you had the sinuses, which we'll see in the next slide, were the frontal bone, the ethmoid, the sphenoid bone, and the maxilla. These sinuses surround the nasal cavity, and they open into these meati. Also opening into the meati is a duct which comes from the eye, and again we'll see that well in the next slide, is a duct which you may have noticed that when you cry a lot, your nose tends to get very, very stuffy. So if you look at your eyes, okay, up here was the lacrimal gland. It produced lacrimal fluid, which by your blinking you kind of push towards the medial side of the eye. Now, you can't keep producing fluid and not removing it, because otherwise it would just flow out of your eyes and you would be crying all the time. So up here on the medial end, you have a little duct present which is called the nasolacrimal duct. And this nasolacrimal duct drains into this inferior meatus of the nasal cavity, which is why when you cry a lot, when you produce a lot of lacrimal fluid, your nose gets stuffy because a lot of it goes into the nasal cavity. Okay? And another thing that you notice up here in the lateral wall is this roof of the lateral wall up here. This is the area where olfactory epithelium is present. It's present on the roof of the lateral wall and the adjoining part of the septum, which is why you need to sniff in order to smell something better, because when you sniff, the vapors will travel all the way up and then only they will hit the olfactory epithelium and stimulate it, and then you'll be able to smell better. Okay? So make sure you kind of read these little bullet points up here, and we talked of paranasal sinuses which open into these meatus. The majority open into the middle meatus. Opening in the superior meatus are some ethmoidal air sinuses, and up here opening into a little recess which is present here. So there's a little recess above the superior meatus up here in this area. There's a little recess present, and that recess is known as the sphenoethmoidal recess. And what do you think would open into the sphenoethmoidal recess? Very good, sphenoidal sinus. Very close to it, so that opens into the sphenoethmoidal sinus. In the superior meatus are what are called posterior ethmoidal air cells. The remaining frontal and then maxillary and the other ethmoidal open here into the middle meatus. And here into the inferior meatus is that nasolacrimal duct that I talked about, okay? So let's take a look at these paranasal sinuses. So look at this picture carefully and notice how the sinuses drain. So this is a coronal section through the face. So here are your frontal sinuses up here, okay? Then here are the ethmoidal air cells. We don't call them ethmoidal sinuses. I mean, you could, but they're really air cells, and they're very close to the medial side of your orbit because the ethmoid bone has these air cells in between. So here are the ethmoidal air cells. You can't see the sphenoidal air sinus because it's deep inside. It's inside up there in the base of the skull. And this is your maxillary air sinus. So all of these sinuses drain by means of ducts. So notice how easy it is for the frontal air sinus to come down and drain into the middle meatus. The ethmoidal air cells drain into the middle meatus or the posterior one into the superior meatus, like that. And notice how the maxillary air sinus has to drain in this fashion. I also want you to pay attention. This is the floor of the nasal cavity. This is the floor of the maxillary sinus. And notice how it has to drain. And if you look at this, SM stands for superior meatus, MM stands for middle meatus. ST stands for superior turbinate or concha, okay? So notice how these sinuses are draining, and then we'll come back to this picture. Okay, before we do that, let me show you these paranasal sinuses. How when an otolaryngologist actually looks at your nose and how you will see these openings. They're very, very small openings.
If we look on the left side of the nose with a thin telescope or endoscope, you see a pink structure to the left, which is the septum. That's the wall that separates the right from the left side of the nasal cavity. On the right side of the field, we see the turbinates. In this case, we're looking at a red middle turbinate. This is bone covered by a membrane that helps to warm and humidify the air we breathe in. Notice we see a small black hole coming into the upper right portion of the field. That is an opening through which a sinus drains. In this case, the left maxillary sinus drains mucus from the left cheek region into the nose through that opening.
So you saw the opening of that sinus. Notice how small that opening was, which is why when you have sinusitis, which is inflammation of the sinus cavity, you can see that opening can be blocked very easily, and that's why the fluid keeps building up in the sinus, but it finds it difficult to get out of the sinus.
So when you, if you're using intranasal steroids, that's where you're trying to get it into?
Yes, when you push anything into your nose, when you spray into your nose, what you're basically trying to do is vasoconstrict the blood vessels in that area. So when there's vasoconstriction, the swelling decreases and you help to open up the sinus openings. You also take steam in. Again, steam does the same thing, helps to open it up.
And when people have polyps, are they in specifically right by that hole, or are they in the sinuses when they do polyp surgery?
When they have polyps, they are anywhere in the nasal cavity, not necessarily next to the sinus hole or inside the sinus. It could be anywhere in the nasal cavity, so they're not restricted to any specific place. Okay. So that was the lateral wall we discussed earlier. So here let's look at the septal part of the nose. It is part bony and part cartilaginous. The posterior part, which you can see here, is bony. It's made up of two bones. The one on the top, this one, is the ethmoid bone. The one below, the lower one, is the vomer, which you may have done in ANP1. And the anterior part, which is here, that is the cartilaginous part. It's hyaline cartilage. And in this anterior part, I don't know how many of you ever have had nosebleeds, but some people are prone to nose bleeding there. So, and usually the bleeding occurs from the septal area, from this anterior part, because up here, you can see this entire septum, and this bone and cartilage is covered by mucous membrane. And under the mucous membrane, you can see how many blood vessels are there, all anastomosing with one another. In the cartilaginous part, especially towards the front area, there's an area here called Little's area after the person who discovered it. The blood vessel anastomosis is even more significant than anywhere else. And those blood vessels are not well supported, so they kind of lie a bit loose. So some people are prone to nosebleeds either because, the blood vessels dilate. When they dilate too much, they can rupture. Somebody might have hypertension, and again, blood vessels under too much pressure, they can rupture. Or somebody has a scab in the nose, and you pick and you tear that, and again, you can do that. And that's where nosebleeds occur. And bleeding from the nose is known as epistaxis. So based on whatever the cause is, the first thing that one can do is you want to stop bleeding before you take care of anything else, is you just put your fingers on either side of the septum and you just pinch your nose like that so that you kind of, put pressure on the blood vessels and then stop the bleeding, and then you take care of, you can go to the doctor and take care of it. Sometimes the bleeding may be so bad that person could get anemic, so they have to actually cauterize the blood vessels. They'll have to kind of burn them and just cauterize them. You might ask, what happens to the blood supply in that area? Because of the anastomosis, the blood supply doesn't suffer. So I asked you all to look at that picture. So when you come to look at the sinuses, which sinus is most disadvantaged when it comes to drainage of its secretions? Excellent, maxillary sinus. So if you look back up here, it is the maxillary sinus, because notice how the duct up here and the opening is high up. So if fluid fills in here, it has to go this way, right? It has to go up, which makes it very difficult. Also, the floor of the sinus is lower than the floor of the nasal cavity. So fluid will tend to kind of collect over here, which is why when somebody has maxillary sinusitis, you often have to do something which is known as postural drainage. Which is, the person, suppose this sinus is inflamed, the person lies on this side so that this sinus is raised, and then this opening, you lie down like that. The sinus is raised so that you kind of help to drain the sinus, okay? Because its opening is kind of lying on top there. All of the other sinuses drain very easily by gravity. They're just coming down. So sinusitis on all of the others is easier to drain. The frontal has another peculiarity to it, like the maxillary had. The frontal is one of those sinuses which, since throughout the day we are standing or sitting and the frontal sinus is highest, it's at the highest point, and drainage is easy, so it can drain down this way. Whereas at night, when you lie down, the frontal sinus is at level with your nasal cavity. So, drainage becomes a bit difficult. So the sinus actually fills with fluid during the night. And then this is a typical feature of frontal sinusitis. You get up in the morning, you get up with a headache because the sinus is so full with fluid, it's stretching the sinus cavity, stimulating nerve endings, you get up with a bit of a headache because whenever you have sinusitis, you have pain in that area. And then as the day goes along, the sinusitis, the pain goes away because then it is easier for it to drain. Okay, so that's one of the things that you see with frontal sinusitis. So if anybody comes to you and says, oh, I have headache in the morning, but it gets better by the rest of the day, you can diagnose and tell them it's probably frontal sinusitis. So here let's review the pharynx. We did this when we were doing lymphatic system. So there were 3 parts to the pharynx. Okay, behind the nasal cavity, nasopharynx, behind the oral cavity, oropharynx, behind the laryngopharynx, behind the larynx, laryngopharynx. Remember the tonsils that we did. So in the nasopharynx, you have the tubal tonsil present here. This was the pharyngeal tonsil. In the oropharynx, there was the palatine and lingual. Now here, in the nasopharynx, there's another structure which you see it, and here was the tubal tonsil, and this tubal tonsil is present over an opening here which is known as the eustachian tube. That's the opening of the eustachian tube, or it's also called the auditory tube, or also called pharyngotympanic tube. I like this name the best, pharyngotympanic, because it helps you to remember what it connects. So here in the nasopharynx is this opening. So I'm going to just move this opening here, which you see, this opening, the pharyngotympanic tube. It connects the nasopharynx, which is pharyngotympanic. What does tympanic tell you? Ear. So it connects the nasopharynx with the middle ear cavity. And if you remember, in the middle ear, there was the opening of the eustachian tube. So it connects the nasopharynx with the middle ear cavity and helps to equalize the pressure in the middle ear with the outside. So that's why when you go up in pressurized cabins or something, sometimes you feel your ears begin to hurt and you swallow, and then it gets better, and that's because you're equalizing the pressure between the middle ear cavity and the outside and through this eustachian tube. In children, the eustachian tube is much shorter, more horizontal, whereas in adults, the eustachian tube is much longer and a little bit more oblique. The entire pharynx has skeletal muscle, which is present actually in 2 layers. There's a longitudinal layer and there's a circular layer. The muscles in the circular layer are known as the constrictors of the pharynx, because they go around, they kind of are present in a circular fashion like this. And they constrict and help to push the bolus of food or air down by peristalsis. You can also see that the epithelium is different in each of these regions, and the epithelium is based on which area it's lying behind. So if it's lying behind the nasopharynx, for example, it will be exactly like the nasal cavity, pseudostratified, and it will be ciliated as well. Oro and laryngo, it will be non-keratinized stratified squamous. So here, these are the structures which are present, just a review. So here you can see the opening of the pharyngotympanic tube. You can see the tubal tonsil, the pharyngeal tonsil, oropharynx, you can see that. And in the laryngopharynx, you don't have anything special opening there. So let's look at this question. How do infections spread to the middle ear? Very good. Yes, through the eustachian tube. Remember, the eustachian tube connected these two areas. And that's why I told you that in children, the eustachian tube was shorter and more horizontal. Makes it much easier for infection to spread in children, which is why very often when children get a cold, it is not unusual for them to get a middle ear infection. So pediatricians often, when a child gets a cold, they want to treat the cold right away because they want to prevent middle ear infection in children because of the short length and the horizontal passage. So it's very easy for infections to travel. It can happen in us too, but just because it's much longer and more oblique, and as adults we take care of our colds on our own, infections don't spread, but they can. Yes.
So when I was younger, I got tubes in both of my ears. Is that true that it's because if you get like frequent ear infections, it's to prevent it, or I just never understood?
When you have middle ear infection, you want the middle ear cavity always just has air. And when it is infected, it is because the lining, the mucosa, has begun to secrete. So instead of air, you have fluid inside. The fluid has to come out some way. It's not possible sometimes for the fluid cannot come backwards through the eustachian tube because it has to go up, right? It can't come out through that. So often they give you antibiotics, and the antibiotics dry up the secretions if the secretions is not too much. But if you have too much secretion inside, it's not able to dry it up. They put tubes, so they create an artificial drainage. So it drains out, and then if that infection was allowed to stay over there, conduction of air from the external ear to the middle ear to the internal ear would be impeded, and you would have hearing loss. So by removing it artificially, they make sure that it heals properly, and your air conduction can go through. So that's a normal way just to allow for drainage. Okay. Okay, again a little bit of review. Which of the following tonsils are present in the nasopharynx? Pharyngeal and tubal. Yes, both pharyngeal and tubal are present, not just the pharyngeal, because the eustachian tube is also present there, and the tubal tonsil is just a collection of lymphatic tissue over that. So from the pharynx, now we move on to the larynx. And this is a cartilaginous skeleton, and the cartilage pieces are covered by fibrous membranes, which are given the name based on which cartilages they are connected to. On the outside, you have mucosa, and then you have muscle, and then you have the cartilage, and then the mucosa kind of goes inside as well. So what I'm trying to say is that there would be mucus covering, and you'll see that in the video. So there would be mucus covering like this, and this mucus would actually go inside and cover it. And those of you who were in the lab must have seen that. You saw mucosa on the outside and inside. If I remove this mucous membrane, then I have muscle which is present, the muscle of the larynx. If I remove that, that's when I actually get to see just the cartilage. Okay? So let's look at the cartilage up here. You have some cartilages which are paired, some which are unpaired. Most of the cartilages are hyaline, as you can see up here. A few are elastic. Epiglottis is one of them, which is elastic, and then you have tinier cartilages called cuneiform and corniculate. So let's look at it from the front. So when you look at it from the front, we often include the hyoid bone when describing the larynx, even though it's not truly part of the larynx. We include it only because it's connected to the cartilages of the larynx by membrane, and it moves with them. So here is this cartilage called the thyroid cartilage, which is shield-like. It looks like a shield. Thyroid means shield. And it has this little notch up here, and this part where this angle is formed, this is what is called the laryngeal prominence. This area here is what is known as the laryngeal prominence or Adam's apple. In men, the thyroid grows and becomes more acute, this part, you know, where the these two sides are known as the lamina of the thyroid cartilage. So it becomes more acute, so which is why this thyroid prominence, especially during puberty, becomes, again, more visible, and you can see the Adam's apple sort of grow in young boys. Hyaline cartilage, single. And this is what is called an incomplete cartilage. What I mean by that is acts like a shield. So you see it in the front, you see it on the side. So this is when you're looking at it on the side. So this is the front, the anterior part. So here you can see this lamina of the cartilage. And then when it goes posteriorly, it just ends like that. So if you were to take a section through the cartilage this way, this cartilage looks like this. Okay, so it's seen in the front, it's seen on the sides, but it is absent posteriorly. So it's incomplete posteriorly. So here's what you're looking at in front, here's when you're looking at it on the side, and then at the side it kind of ends in a long border up here. Below that is this cricoid cartilage, also a single cartilage, hyaline in nature. The cricoid is a ring-shaped cartilage. So in other words, it is present all through. So it's present all through. It's ring-shaped. So this is as if you're looking at it from the top. But if you notice the cricoid, and if you look at it from the side, the cricoid is a cartilage which is narrower in front. This is anterior, but broader at the back. So it looks somewhat like a signet ring. Okay, so let's take a look at that. So here is the cricoid in front anteriorly. Notice how narrow it is. As you keep going laterally and posteriorly, see it's increased in sort of height. And here you're looking at it, so you can see it laterally. And this is the posterior part of the cricoid. So see, it is widest posteriorly, narrowest anteriorly. Okay? The thyroid and the cricoid are connected to each other by this fibrous membrane. And what do you think this membrane would be called? Very good. Cricothyroid membrane. And the central area is usually thicker, where it will be just called cricothyroid ligament. It's really part of the membrane, just thicker in the center. And here the thyroid is connected to the hyoid. So what would this be called? Yes, thyrohyoid membrane. Thyrohyoid membrane, okay, because it's between thyroid and hyoid, and then in the middle it is thick, it will be called thyrohyoid ligament. Also anteriorly, you can see a little cartilage peeping out. This cartilage is the epiglottis. The epiglottis is actually attached to the posterior surface of the thyroid. So if I was to kind of draw it, this is how it would be attached. So it's attached to the posterior surface of the thyroid, and that's why you can see a little bit of, here. It's attached to the posterior surface of the thyroid, and that's why you can see a little bit of it peeping above the hyoid bone. So here's the epiglottis. You see it best from the posterior aspect. Epiglottis is also single, but it is elastic in nature. Then when we look at the posterior aspect here, so here we are seeing this incomplete part of the thyroid. In other words, it's not there posteriorly. Here we can see the cricoid posteriorly. Sitting on top of the cricoid are two cartilages. So this is a paired cartilage called the arytenoid cartilage. And here is the epiglottis. So you can see the epiglottis up here. And on top of the epiglottis are the corniculate and cuneiform. So this arytenoid is actually connected to the epiglottis by a little fold of mucous membrane. That fold of mucous membrane can just sort of sag. So you want to keep it a bit stiff. So to keep it stiff are the corniculate and cuneiform, which is, the other one is not shown, so it will be present up here like this. So they just keep that fold stiff. And you can understand that this epiglottis, it acts like a lid over the larynx, because during swallowing what happens is this epiglottis folds back and completely covers the larynx like this, so that food does not go into the larynx when you swallow. Okay? So let's take a look at how that happens.
Swallowing occurs in two stages, the oropharyngeal and esophageal stages. start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oral pharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis initiates.
So this part we'll see when we do the digestion. So this is the reason why they tell you that do not talk when you're eating, because what happens when you talk, ideally the epiglottis acts like a lid, but when you talk from below, the air pressure comes, it opens the epiglottis so food can go through into the larynx, okay? And that's why you cannot, the pharyngeal muscles, even though they are skeletal, they're really not so much under your control because they act really fast, because breathing is, as it said in the video, breathing is stopped when you swallow. You do not want breathing to be stopped too much, so that's why you want all of it to go down really, really fast. So that's why pharyngeal muscles are skeletal, but they're not totally voluntary, because if they were, then you could stop breathing for a long period, which would kind of create problems.
Would you point out cuneiform and corniculate?
You can't see both. Cuneiform is sitting on top, corniculate are up here. In fact, it's not even sure whether this is cuneiform, usually because it's really, really small. So these are extremely tiny cartilages which sit on top of the on top of the arytenoid in this airy epiglottic fold. Okay.
So when somebody chokes like say on their food, is that where
It would, yes. When somebody chokes, it is because it's gone down into the larynx. The epiglottis has not done the job, or maybe they were talking or doing something. So it's gone into the larynx, and then when you do a Heimlich, what you're doing is you're increasing the pressure inside, and you kind of blow that thing from below and push the bit that went into the larynx. Yeah. So here are the muscles of the larynx. So as I said earlier, so imagine that you remove the mucous membrane so you can see these various muscles. There are a lot of muscles. The one muscle I do want you to kind of pay attention to is one muscle up here, which is called the posterior cricoarytenoid muscle. It's important because it's the only muscle which abducts the vocal cords. By abducts the vocal cords means if you look at the vocal cords, this is a position where the vocal cords are far away from each other. When the vocal cords are close to each other, this is adduction, and this is abduction. So air passes between the vocal cords. So naturally, if they are abducted, more air can pass in and go into the larynx and trachea. So this is a very important muscle because it's the only abductor of the vocal cords. In fact, it's called a life-saving muscle, because if this muscle was paralyzed, what would happen? The adductors would take over and the vocal cords would be very close to one another, so it would be difficult to breathe. Inside the larynx, so here we had muscle, and then covering this and going all the way inside is mucous membrane. Now this mucous membrane inside the larynx is thrown into two folds, which you can see, and all of you should have seen it in the lab. So these folds go from back to front, and they go from the arytenoid cartilage to the thyroid cartilage. There are two folds present. The one on top is known as the vestibular fold, or also called the ventricular fold. It's known as the false vocal cords. These are further away from each other, and we'll see a view where we can see it from the top. These are further away from each other. Below that is a second fold which is present, which is really fibrous. These folds are basically fibrous tissue covered by mucous membrane. The second fold is between the arytenoid and the thyroid cartilage, so going from back to front. This is called the true vocal fold, or also called the vocal folds, or also called the vocal cords. And these are closer to each other. And the space between the vocal cords, so this is showing you one side. So imagine there'll be another one on this side, right? So if I look at it from the top, These will be the vestibular folds, which will be further apart, and these will be the vocal folds, which will be closer to each other. The space between the two true vocal folds is known as the glottis. That is the narrowest part of the larynx. And so therefore, that's why I said abduction is important, because that's the only way that more air can get into the trachea. So let's look at these as seen from the top. So here is it. So if you were looking into the larynx from the top, here's the epiglottis. So you're looking from the top. Here's the epiglottis. Here, this part here, down below would be the arytenoid, and here are your corniculate and cuneiform, which connect the arytenoid to the epiglottis, okay, in the fold. So you're looking from the top. These are your vestibular folds further away from each other. Here are your vocal folds. Vocal folds, when you look in, look pearly white, actually, because they don't have a good blood supply. And this is the space between them, which is the glottis. So here the vocal folds are abducted. Notice here when they're abducted, you can see into the trachea, and you can see the tracheal rings. So let's take a look at this as if you were putting a scope inside.
Hello! I haven't had visitors in so long.
What are you?
I'm a voice box.
So this part here, watch this, okay? This is the vocal cords, and these on the side are the vestibular folds. So notice how the vestibular folds are further away.
Will call me a larynx. See my two vocal cords moving apart and together as I talk? They come apart so that the air can get through them, and they come together to vibrate and make sound as I exhale. Let me show you.
So you could see that really well as you were looking inside, right? So the function of these vestibular folds, which are further away, when needed, these vestibular folds can come close to each other and they can act like a sphincter. But you don't want them to come too close all the time, because if they do, then they would block the airway. So if these vestibular folds actually came very close to each other like this, what would happen? They would block the airway totally. And that's what happens in anaphylaxis and in a condition known as angioneurotic edema. Angioneurotic edema is a severe case when someone has an allergic reaction. There is edema in many parts of the body. That edema affects this vestibular fold, so they get really thick and swollen, and then they come very close to each other, so they completely block the airway and they prevent air, and the person could die. So you would really have to immediately give them epinephrine or adrenaline to cause vasoconstriction. Now the function of the vocal cords is to produce sound. So we have something called the pitch and something called loudness. The pitch of this voice, it can be either high-pitched or low-pitched. The pitch is based on the vibration of the vocal cords. The faster they vibrate, the higher the pitch. The slower they vibrate, the lower the pitch. Women tend to have higher pitched voices because our vocal cords are shorter and they are lighter. So if it's short and light, it makes it easy to vibrate faster, so producing the higher pitch. Men have longer vocal cords because, remember I told you the thyroid cartilage, so if this is the thyroid cartilage seen from the side, in males this thyroid cartilage grows, and that angle, remember that laryngeal prominence grows a little further. So during puberty when their voice breaks, that's because actually the thyroid cartilage is growing, so the vocal cords are getting longer. So if this was the initial length, now they get longer. So men have longer vocal cords, plus they are thicker. Because they're longer and thicker, it makes the vibrations much slower, which gives rise to their deeper or lower pitched voices. Loudness is based on the amount of air that comes from below and makes those cords vibrate. So when more air comes from below, your voice is much louder. When less comes, your voice is usually a whisper. So when people have a condition known as laryngitis, at that time what happens is the larynx is inflamed. and people tend to whisper at that time. And when you whisper, the cords do not move far away because less air is coming from below, so the cords are very close to each other. They're still vibrating, so they're closer to each other, they're still vibrating. Now, because they are swollen, if you whisper when your larynx is inflamed, what happens, you make these cords rub against each other even more, and you inflame them even further, you irritate them even further. So when someone has laryngitis, that's why they tell you give voice rest, don't talk. Or if you must talk, it's better to talk in a normal voice, not whisper, because if you talk in a normal voice, you're making the vocal cords go further away from each other because it's a bit louder, and you'll prevent that friction, you know, the cords from kind of rubbing against each other and friction. So whispering is really not a good thing to do when you have laryngitis. It's better to either keep quiet or just talk in your normal voice. So here, let's do a bit of review. Which of the following cartilages prevents food from entering the trachea? Epiglottis, very good. Then from the larynx, let's move to the trachea. So it begins below the cricoid cartilage. It also has hyaline cartilage, but instead of being one piece, the hyaline cartilage is seen as the form of C-shaped rings. So you can see there's this C-shaped ring which is present. And posteriorly, the trachea does not have cartilage. Instead, it has a muscle present, which is called this part here. The muscle here is called trachealis muscle. So posteriorly, it has trachealis muscle. And if you take a section here through this part, lying directly posterior to the trachea is the esophagus. Because remember, the pharynx divides. Anteriorly, it becomes the laryngopharynx. Anteriorly continues into the larynx, which will become the trachea, and posteriorly the laryngopharynx will become the esophagus. So here the esophagus lies directly posterior to the trachea. This trachea bifurcates at the level of the sternal angle. And remember where the manubrium and the body of the sternum meet? That part was called sternal angle, which is at the junction, if you take it, it's at the junction of T4 and T5 vertebrae. So the sternal angle corresponds posteriorly to the junction of the T4 and T5 vertebrae. Where the trachea bifurcates, there the cartilage, instead of being a C-shaped cartilage, kind of is a bit triangular. To me, it looks like a diaper, so that's why I call it a diaper-shaped cartilage. That area is known as the carina. And actually, when you do a bronchoscopy, you can really see a little sickle-shaped fold inside. If you look inside, you peep inside, you can see a sickle-shaped fold at the region of the carina, and that shows you where the two bronchi will be present. So the trachea divides into two what are known as primary bronchi, a right primary bronchus and a left primary bronchus. Each primary bronchus then divides into a secondary bronchus, which goes to the lobes of the lungs. So these are also known as lobar bronchi. The secondary bronchi are also called lobar bronchi. Secondary are also known as lobar bronchi. And that is what you can see here, lobar bronchi. There are 3 lobar bronchi on the right side, 2 lobar or secondary bronchi on the left, because the right lung has 3 lobes and the left lung has 2 lobes. That's why you have 3 on right and 2 on left. Each secondary bronchus then divides into the 3rd level bronchi, which are known as tertiary bronchi. There are 10 tertiary bronchi in total in each lung. The left may have 8 because 2 may fuse, but for all practical purposes, those actually then divide. So we have 10 tertiary bronchi. These tertiary bronchi then go further and become 4th level, and then 5th level and 6th level, and so they keep going on till the bronchi end up as being bronchioles, where they lose their cartilage. And from bronchioles, then they will lead into the alveoli or the air sacs, which we'll see. So here let's look at a bronchoscope when introduced inside.
Following topical anesthesia of the airway, the fiber optic bronchoscope is introduced orally. The epiglottis is observed anteriorly. The bronchoscope is then directed under the epiglottis where the laryngeal structures, including the vocal cords, are seen. The tip of the bronchoscope is advanced past the vocal cords and into the trachea. Note the anterior cartilaginous tracheal rings.
So you saw how the rings were, and then they would go into each of the individual bronchi. So why do you think you have trachealis muscle on the posterior aspect of the trachea? Good, very good. To avoid pressure on the esophagus, not pressure on the sternum. Remember, the trachea lies behind the sternum. There's cartilage in the front. So its cartilage is related to sternum, even though actually the heart is lying in front. And that's why I showed you this picture where I purposely said that lying posterior to the trachea is the esophagus. That's why you have muscle here, because if you had cartilage, it would make swallowing very difficult. It would compress the esophagus, and it would prevent you from swallowing properly. There'd always be that little, you'd feel that. So that's why you have muscle against muscle to prevent compression of the esophagus. Oh, let me go back. I forgot to tell you this before I ask you this question. So let's look at these two bronchi, the primary bronchi. So when you observe the primary bronchi, first thing that you can see is that the right primary bronchus is shorter than the left one. Notice this length of the left, okay? Much longer. The right one is shorter. The right one is also wider compared to the left one. Notice this, the width. The right is also more in line with the trachea. The left is kind of a little more horizontal or more oblique. So these are some differences between them. So if somehow you swallowed a peanut, like, say, Tommy did, which of the bronchi do you think it's more likely to enter? Right, yes, because it is wider. So let's take it here. Wider, more in line with the trachea. So peanut is likely to take the path of least resistance, right? It'll come down there. I don't know if you read many years ago, maybe a year or so ago, there was this guy who had a tree growing inside his bronchus. They noticed that, and that's because a small little seed can go in, and you may never know it's gone in because, you may have coughed a little and that's it, and it didn't irritate your bronchus all that much. So it probably remained there, nice medium, because it's fluid, there's mucus being produced, and I actually noticed a little tree. When I say a tree, it's not like a big acorn tree is growing in there, but a little, small little shoot probably. No, they had to surgery. There was a lot of inflammation and scar tissue. They probably had to, do something more. So here's the bronchial tree. So, here we have the primary, then the secondary or lobar, then it becomes the tertiary bronchi, which are also, because we'll see that they go to areas of the lung. So tertiary bronchi are also known as segmental bronchi. Tertiary also called segmental bronchi. And then they get smaller and smaller, so they're 4th level, 5th level, 6th level. They keep going on till they become bronchioles. Bronchioles then become really, really small, and then we call them terminal bronchioles. and then they lead into structures called respiratory bronchioles. Respiratory bronchioles are bronchioles which have alveoli which bud out from the sides of their walls, which you can see up here. And respiratory bronchioles onwards are part of the respiratory zone, remember, where gas exchange takes place. Then a respiratory bronchiole will get, and you can see these alveoli budding off from the walls of respiratory bronchioles, and then they lead into alveolar ducts and so on, and finally lead into alveoli, which you can see here. Also notice up here the pulmonary vein and artery following, and we saw this in the first few slides where you can see that capillary plexus, and this would be what would be present in the interalveolar septum, and that's how gas exchange takes place. Okay. Some important things to see here are that the sympathetic nervous system causes bronchodilation, because remember, sympathetic does everything to make your body alert for any contingency that could happen. So if you're frightened or you need to fight or something, you want to be able to breathe better. So naturally they have to dilate the bronchi so that air can go in. Parasympathetic has the opposite action. It causes bronchoconstriction. Now these blood vessels, the pulmonary blood vessels, they were only for gas exchange. They did go to the lungs, but they only were for gas exchange, and we did this in the beginning. If this was an alveolus and here's another alveolus, this is the part in between which was called the interalveolar septum, and that's where these capillaries are lying, the pulmonary capillaries. So I'm going to draw this here. And I don't know if I mentioned the respiratory membrane. Did we talk about that? Maybe not. Okay, so here is a capillary which is present in the interalveolar septum. So if I magnify this, so here is a capillary which is lined by squamous epithelium, and here is an alveolus of this side. Okay, an alveolus of this side. And remember, the alveoli had type 1 cells, which were squamous epithelial cells. Type 2 were the ones which produce surfactant. So here again we have type 1 cells, squamous epithelial cells. So carbon dioxide from this end of the capillary will pass through and get into the alveolus. So this is carbon dioxide. Oxygen from the alveolus will pass through this way and get into the venous end of the capillary, and this is what will take it into the left atrium, and this is from the right ventricle, right? Do you remember that? So this area, this thickness is what the gas exchange has to occur through. So it is going to occur through the capillary endothelium, which is squamous cells. Then the basement membrane, which this endothelial lies against. So basement membrane. And the basement membrane of the capillary endothelium and that of the alveolar epithelium both fuse. So it's the fused basement membrane. And then the last structure is the squamous epithelium of the alveolus. Squamous epithelium of alveolus. So these three structures form what is called the respiratory membrane. You can see that it's very, very thin because it's squamous on both sides and just the fused basement membrane. You never want it to become thick, because if it was thick, then it would prevent diffusion of gases. When someone has problems with the heart, like we already did the cardiovascular system, you remember if someone had a mitral valve problem, so mitral valve was stenosed, what happened? Blood would back up into which chamber of the heart? Left atrium, right? Left atrium. And so blood from the lungs will not be able to drain into the left atrium. So it will go back into the pulmonary circulation. So that means all of these capillaries would be engorged. Okay? So where would that engorgement be? It would be in this area. So when the capillary is engorged, fluid leaks out. When that fluid leaks out, it will go here. So can you see it's going to make the respiratory membrane much thicker because fluid has leaked out, which is why gas exchange will not occur, which is why somebody with mitral valve problems ends up with breathing problems because of that pulmonary congestion. Okay? So pulmonary capillaries were for gas exchange. But what about all these bronchi and the bronchioles? Because they are tissue, they have connective tissue, they have muscle tissue, epithelium. They need to be supplied by blood, by nutrition. That blood to the actual bronchi and the bronchioles come from vessels which have the same name, called bronchial vessels. So bronchial arteries provide nutrition, oxygen to them, and bronchial veins take the blood back from these tissues and go back into the circulation. Okay? So pulmonary capillaries do not supply these with nutrition. They only go for gas exchange. But the actual tissue is supplied by bronchial arteries and veins. So let's see. What is present? So let's review. What is present in the interalveolar septate? Pulmonary capillaries, yes, very good. Type 2 cells are present lining, type 1, sorry, are present lining the alveoli, not in the septum. In the septum were the pulmonary capillaries.
Type 1, I'm sorry, lines which?
They line, type 1 and type 2 cells line the alveoli. Now we'll come to the lungs. So a lot to read, you can read up here. So, you know, the lung, you have two lungs. They are surrounded by the pleural cavity, and just like the pericardium, there is a visceral layer of pleura which is intimately attached to the surface of the lung. Then there's a parietal layer which lines the inside of the thoracic cavity. Between them is the pleural cavity which has a little bit of fluid. Lungs are conical in shape, so they have an apex which is up here towards the neck and a base which rests on the diaphragm. We look at the surfaces of the lung. Then the lungs are divided into lobes by deep grooves which are known as fissures. Both lungs have what are called oblique fissures, whereas the right has an extra fissure called the transverse or horizontal fissure. So you have 3 lobes in the right lung and only 2 on the left lung. On the medial surface of the lung, or what is known as the mediastinal surface, because remember the mediastinum was the area between the 2 lungs, that's where you have the hilum. We did the hilum when we were looking at lymph nodes. So similarly, hilum just means gateway. So there we will see all these structures which enter and leave the lung. So we'll be looking at that. I told you about the respiratory membrane and what it is, how the sympathetic and parasympathetic fibers act. So let's look at some of these features. So here, this area in between was called mediastinum. This area in between where the heart is lying, this is known as the mediastinum. So you can see that both lungs face the mediastinum. The lungs are surrounded by this pleural cavity. So the layer which invests the surface of the lung is intimately attached to the surface. You cannot separate it. That is called the visceral layer. This layer which lines the inside of the thoracic cavity is the parietal layer. In between them is the pleural cavity, which has very little thin fluid which lubricates the lungs. As the lungs expand and contract, it helps to cause frictionless movement. So the lungs are only surrounded, they don't lie within the pleural cavity, just like the heart. And let's take a look at this question before we go further. Which of the following statements is false? Very good. Yes, the inner wall, the inside of the thoracic cage is lined by parietal pleura. Remember, it's the lungs which are lined by visceral pleura, not the inner wall of the thoracic cage. See, this is the inner wall of the thoracic cage, this part here, that's parietal pleura. It's the lungs which are lined by visceral pleura. Here, this is the inner part of the thoracic cage, parietal pleura. All of the other statements were correct. The trachea does bifurcate at the sternal angle. Bronchi are supplied with oxygen by bronchial vessels. Sympathetic nervous system does cause bronchodilation, and pulmonary vessels are responsible for gas exchange. So here when we look at the lungs from in front, you can see this is the apex of the lung up towards the neck. This part is the base of the lungs, which is resting on the diaphragm. So we'll see when we do the movements of the diaphragm, how when the diaphragm descends, the lungs descend with it, and so therefore their volume will increase. Here are the fissures. There's an oblique fissure on either side. On the left side, it divides the left lung into an upper and a lower lobe, or superior and inferior lobes. On the right lung, you have another additional fissure, which is called the horizontal or transverse fissure. So you have upper, middle, and lower, or superior, middle, and inferior lobes. You can call them upper or middle. Then if you look at the surfaces of the lungs, this would be the sternocostal surface, or the anterior surface, because it's related to the sternum and the ribs. This part here would be the diaphragmatic surface, because that's where it's sitting on the diaphragm. And this area here, which we'll see, if we turned around the lungs, we'd be able to see it better. That would be the mediastinal surface, this on either side. In the left lung, because it has the heart related, remember the heart was present more on the left side, the left lung is kind of indented a little bit, and that indentation is known as the cardiac notch. And there's a little tongue-shaped process which is present there. Just below that cardiac notch, that tongue-shaped process is known as the lingula. Remember, anything to do with tongue was called lingual. So lingula. So this little tongue-shaped process, which you may or may not see obviously, but it is present, is called the lingula. Now this is the lung when you look at the mediastinal surface or the medial surface. So if we took a section through this part, all of this would be the antro and lateral surfaces. Here is the heart, here is the mediastinal area, and this is where structures enter or leave the lung. So this part here is what is known as the hilum of the lung. At the beginning where they enter or leave, that part is known as the root, and then when they completely go into the lung, that area is called the hilum. So the root is where they are attached to the mediastinum, the hilum is where they enter or leave. And notice you'll have a bronchus. Remember, the primary bronchi will get into the lung. The pulmonary veins will come from the lungs and they'll come out of the lungs because they're bringing blood to the heart. And the pulmonary artery will go from the heart to the lungs. So they are entering the lungs, the veins are exiting the lungs, and the bronchus is entering the lungs. So these are the main structures there. But apart from that, you also will have lymphatics which are present here. So in carcinomas, these lymph nodes get really swollen and can be observed. And you'll have nerve plexus, that sympathetic and parasympathetic, they travel with them and they get into the lungs and they innervate the bronchi and the bronchioles. Okay? So this is what is seen at the hilum. Now when you get into each lung, remember we said there were 10 tertiary bronchi. These tertiary bronchi actually go, so we had the primary bronchus, the secondary bronchus, and then we had tertiary bronchi. Each tertiary bronchus, if I just take one tertiary bronchus, it goes to a particular segment of the lung, and that segment kind of looks wedge-shaped. That segment of the lung is known as bronchopulmonary. The broncho is part of the tertiary bronchus, and the pulmonary is the lung tissue. So obviously there will be 10 bronchopulmonary segments, right? If there are 10 tertiary bronchi, they would go to 10 segments of the lung. So there'll be 10 bronchopulmonary segments in each lung. It's wedge-shaped or pyramidal in shape. The importance of these bronchopulmonary segments, and these are the bronchopulmonary segments seen, the importance are they are like little lungs within a big lung. So they are independent functional units. So they have their own pulmonary artery, they have their own bronchus, and the veins and the pulmonary artery and the bronchus lie in the center of the each segment, but the veins kind of lie intersegmentally. So the veins are in between, which is rather convenient for us because I said each segment is kind of its own functional unit. Sometimes these segments get affected. If somebody has lung abscess, or let's say like that peanut which went into the right bronchus, it can go down and it can go down into one of the tertiary bronchi. So suppose it goes down and nobody pays attention. So let's say it's gone here. It completely blocks this tertiary bronchus. This part of the lung will collapse, right? So then it's not functioning. So you may need to remove that. Or that part of the lung may form a lung abscess where you have to remove that. Or that part of the lung may be affected by tuberculosis, or any part may be affected. You can remove these tertiary bronchi with the bronchopulmonary segment without affecting the function of the others, because these veins lie in between. What you do is you just block you close off the artery and the bronchus, and you kind of dissect in between this connective tissue where the veins are present. Veins don't bleed too much, and it makes it convenient for surgeons to dissect so they don't cause too much bleeding. They can kind of just scoop out this affected bronchopulmonary segment, just remove that, and the rest of the lung remains in place. You can even remove a whole lobe of the lung like that and leave the other part of the lung remaining in place. So that's the importance of this. This process where one particular area of the lung is, if the bronchus to it is blocked and the alveoli collapse, that condition is known as atelectasis. So atelectasis is collapse of the alveoli. So obviously if they are collapsed, that area of the lung is not going to be functioning. This is just a chest x-ray. You've often, all of you must have observed it or seen it at some time. So when you look at a chest x-ray, anything which has air always shows up as dark. Anything which is fluid or bone or cartilage shows up as radio-opaque, white. So muscle too. So here you can see this is the diaphragm. The right dome of the diaphragm is higher than the left dome. Here's the heart present over here. Here are the lungs filled with air. And normally this area here, the pleural cavity, should be free. Usually you should not see any, this should be kind of a sharp margin like here. If somebody had fluid in this area would not be sharp. It would show up as white, and then you would see a fluid level in that area. You can also see air in the trachea up here. So this person has a normal chest x-ray. So I mentioned if there was fluid in the pleural cavity, that would kind of show up, on an x-ray. So that condition where there is fluid in the pleural cavity is known as pleural effusion. The word effusion means collection of fluid. I think we mentioned it when there was pericardial effusion. If the pericardial cavity was filled with fluid, that's called pleural effusion, pericardial effusion. Similarly here, fluid in the pleural cavity, which could be, let's say somebody got a viral infection, or there was general septicemia, or anything which irritates the pleural membranes could cause pleural effusion. So here you can see that the pleural cavity is filled with fluid, and obviously you have to drain it, because once it's filled with more fluid than it should have, you can't do much about it. You have to remove it. So you remove the fluid and you kind of, drain it into a bag. And pneumothorax is another condition which is air in the pleural cavity. Air in the pleural cavity. This can occur because, let's say someone got a stab wound. So imagine you get stabbed like that. So you open up the pleural cavity, air gets in from the outside. Or it could also happen where people have a condition known as emphysema, where because of, usually due to constant smoking, it is where the alveoli, the septa between the alveoli are broken, so the alveoli become really dilated air sacs. So instead of being small air sacs like this, you get huge air sacs. And on the surface of the lung, you might see little blebs like that. Any of those can rupture. So if it ruptures you're breathing in air, so air now gets into the pleural cavities. Either it could be from outside or from inside. So the pressure in the pleural cavity always should be negative, because if it is positive, what would it do? It would compress the lungs, and you don't want that to happen. But if air gets into the pleural cavity, you can see that air can increase, it can keep getting more and more, so the pressure inside becomes positive. What does it do? It pushes on the lungs and the lungs collapse, and that's what leads to atelectasis. That's one of the ways that atelectasis can happen. Air, even effusion, but air, when it enters suddenly and fills up real rapidly, you get what is called tension pneumothorax, and that becomes a medical emergency. You have to remove the air really promptly, otherwise one lung will totally collapse. When this collapses, it can actually push the entire mediastinum to the opposite side, and it can become really, really fatal. So you have to remove that air promptly. So let's say I told you atelectasis happens. So if the alveoli collapsed, which would be primarily affected? Gas exchange, yes, gas exchange. Conduction of air is right from nose, down the trachea, down the larynx, down the trachea, down the bronchi, down the bronchioles. All that is still happening. But when it gets to the alveoli, they have collapsed and gas exchange is not occurring. So that's what is going to be primarily affected. So here are some clinical conditions. We've talked of most of them. Laryngitis was inflammation of the larynx, and I told you how whispering was, it was better to just be quiet or talk normally, not to whisper. Angioneurotic edema is something like here, where usually happens in anaphylaxis, which is severe allergic reaction, where tissues everywhere tend to get edematous. It affects the vestibular folds. They get so swollen that they come very, very close to each other. They can come very close to each other and completely block the airway. So again, you have to quickly take care of this. COPD stands for chronic obstructive pulmonary disease. Yes, COPD stands for chronic obstructive pulmonary disease. Chronic bronchitis and emphysema are part of this chronic obstructive pulmonary disease. Here, if the bronchioles are constricted, like in chronic bronchitis because they are constantly irritated, or in emphysema, as I told you, the alveoli, the walls between the alveoli here, the walls between them are broken. So the alveolus is like one big bag like that. Very difficult to push air out. So air keeps coming in, the alveoli just keep getting dilated. So it's somewhat similar to having stale air remain in the lungs. So these people have difficulty breathing. That difficulty breathing is known as dyspnea. Okay, dyspnea is difficulty breathing. Pleuritis is just inflammation of the pleural membranes, which usually leads to effusion, and pneumothorax was air in the pleural cavity. Atelectasis, I told you already, was collapse of the alveoli.